I'm Dr. Zemeneu Hassen, a psychiatrist in Sitota Center for Mental Health. I'm happy to get this chance to present few points about schizophrenia and its management. To say a few pointers, this schizophrenia is a chronic mental illness with exacerbations and readmissions. It's one of the cause of repeated admission to psychiatric centers with that of bipolar disorder and substance use disorders. It's highly stigmatized by the family, the community, the patient, and even the professionals. So the patients suffer too much with this illness. They don't get sufficient support by the community. It affects thought, mood, and behavior. It's also called a thought disorder. When thought is affected, mood will be affected and the behavior will be affected. As I have said, most admissions to psychiatric centers is due to this illness. They occupy a significant percent of beds in the inpatient management. Mostly patients do not have insights about their problem. That will be a challenge for adherence to treatment and even to come to get the service. Mostly they are brought by family members, friends, or other collaterals. Epidemiology, it has a familial inheritance. When one family member is affected, there's a high risk for the other members to have this problem. When one parent or two parents are affected, there's a high chance to occur in the children. The male to female ratio is 1:1. Male and female are equally affected, but the prognosis is better in females. Mostly females have the paranoid type of schizophrenia, and in females, later onset of the illness, whereas in males, early onset and mostly the disorganized type. It affects 1% of the community, whether in developed country or in developing countries, whatever the ethnicity, the social background, almost it has a similar prevalence. As I have said, it is earlier in males than females. It affects mostly productive age group. So the cost for schizophrenia is very significant, both the direct cost and the indirect cost. When productive age group is affected, he or she can't get sufficient income, then he or she can be dependent on the family, on other members of the family, so that it has a high cost. About the pathophysiology, mainly it is high level of dopamine in the mesolimbic and mesocortical area. In fact, the dopamine level can be higher also in the other pathways of the dopamine, the nigrostriatal, the tuberoinfundibular. That's why side effects are common when antipsychotics are used. As I've already said, there's a genetic risk and other neurotransmitters like serotonin is involved. But even the typical antipsychotics are also called dopamine serotonin antagonists. Even the GABA, glutamate, noradrenaline are also involved. Social factors contribute also for the development of this illness, like early parental loss before the age of 11. There is a high risk to develop schizophrenia. Other chaos in the society, in the community, can contribute for the development or the course of this illness. Psychological makeup of the individual is also one factor. There are also structural and hormonal changes in in the brain and other parts of the body. The criteria, 2 out of 5 should be involved. That is one is having perception without external stimuli, hallucination, most commonly auditory hallucination. The other sense organs can also be involved. A fixed belief against the background of the patient, delusions, mostly persecutory delusion and delusion of reference. Disorganized speech to have tangentiality, circumstantiality, verbigration, and the like. Disorganized or catatonic type of behavior and negative symptoms, especially the negative symptoms are a challenge for the management, the functional impairment, the poor prognostic factor, and not responding well for the typical antipsychotics, and hampering the social life of the individual. Positive symptoms are better for the treatment response than the negative symptoms. Negative symptoms more influence on the life of the patient. One criterion can be enough if the delusion is bizarre or the hallucination is being running commentary or conversing type of hallucination. So the minimum duration is 6 months. If it is lower than 6 months, it is brief psychosis. Between 1 month and 6 months, schizophrenia 4. 6 months and above, schizophrenia. There should be distress or functional impairment on the individual. If he is a physician, for example, lower to other medical level. If he is a lawyer, lower level of functional involvement. So functional impairment and distress is a criterion. Rule out substance. One of the challenges to differentiate between substance-induced psychosis and schizophrenia, or psychosis secondary to general medical condition like hyperthyroidism and hypothyroidism. Follow the chronology of the illness, the use of the substance and the development of the symptoms of psychosis, and the remission or the improvement of psychotic features after quitting the substance. This is more to substance-induced psychosis. In the case of schizophrenia, symptoms persist even if the patient has stopped using the substances, and more functional impairment observed in schizophrenia rather than substance-induced psychosis. Rule out intellectual disability in children, and personality disorders should be ruled out. So the presentation of the patient mostly having the positive symptoms, persecutory delusions and auditory hallucinations, mostly without insight for the patient. Loneliness and social isolation, asociality, they will not socialize with other individuals. They may wander in the village, even collecting unnecessary things and rubbish, poor self-care, and even this is a stigma. This individual is mad or unnecessary for the community and the like. Occasionally, they can be verbally and physically aggressive. The aggression in schizophrenic individuals is not as such significant than the other type of personalities like narcissist type of personalities. Mostly patients, they don't have insight. They will visit the psychiatry center being pushed by the family members, policemen, or other ways in such that the individual is not aware of the condition. So most admissions are involuntary for the safety of the patient and for the safety of the family and also for the community. So as a self-medication and also as a comorbid condition, most schizophrenic patients abuse substances, smoking cigarettes, chewing chat, and drinking alcohol. Previously in Emmanuel Hospital also, most patients, they share cigarettes together, they smoke together. In fact, smoking somehow reduces positive symptoms, but the tar content of the cigarettes affects the life of the patient significantly. When you approach a patient or evaluate the patient, proper history should be taken from the patient if he or she can give certain things, mostly unreliable from the patient. Then the collaterals are very important to get sufficient history. Some points can be obtained from mental state examination. The appearance can be disavowed. By the way, they can be also well-groomed in paranoid type of schizophrenia. Well-groomed individual with persecutory delusion and hallucination can be there. And the disorganized type can be in disavowed appearance. Guarded behavior, uncooperative behavior, even suspicious of the physician. Why I'm brought here? I will give no history at all. What is the reason to bring me here? Guarded and uncooperative. Inappropriate affect with giggling, grimacing, and even constrictor type of affect can be observed on the face. The speech can be disorganized with tangentiality, circumstantiality, and other types of speech abnormalities. In the thought content, you can find the persecutory delusion. The delusion of reference is in the thought part, can have auditory hallucination mainly or other form of hallucinations on the perception. Easily destructible on the concentration that may make difficult to diagnose with manic patients. Mostly their memory is intact, by the way. Even schizophrenic patients can tell about their background properly or any facts in the history properly. Abstract thought concrete, rather than knowing the meaning of the abstract proverbs and the like. They miss and they give you just the concrete message of the proverb. On laboratory, mostly it's not important to do invasive laboratory investigations. The history and the mental state examination is indicative of the diagnosis, but to rule out underlying medical conditions and to see whether there is metabolic syndromes. The lipid profile and other laboratories can be done. Otherwise, the diagnosis is mainly clinical to take proper history and to do mental state examination. Coming to the management, it can be inpatient and outpatient management. The clinician will decide whether the patient should be admitted or to be in the outpatient level. Mostly the treatment is long-term for a long period of time to be on antipsychotics. The backbone of the management is the antipsychotics with psychotherapists to support somehow the antipsychotic medications. So antipsychotics can add benefit on the psychotherapist can add some benefit on the antipsychotic treatment. The adherence to treatment is crucial. Those who are adherent to their medications, they have good clinical improvement than those who have erratic use of the drugs. Antipsychotics, they are not selective. They can block the different dopamine pathways, the nigrostriatal, the tubuloinfundibular, the mesolimbic, and mesocortical pathways, so that extrapyramidal side effects develop since the antipsychotic medications are not selective in the dopamine pathways. We have first generation or typical antipsychotics and second generation or atypical antipsychotics. The first generation or typical antipsychotics have more extrapyramidal side effects than the atypicals. The atypicals or the second generation antipsychotics more metabolic syndrome than the typicals or the first generation antipsychotics. The typical antipsychotics can be low potent or high potent. The low potent typical antipsychotics cause more sedation and postural hypotension. The sedation may be beneficiary for the patient who is agitated with poor sleep. The postural hypotension can cause falling down and dizziness when standing from sitting or lying position. We have in this group chlorpromazine and tioridazine. We have 25 milligram chlorpromazine and 100 milligram chlorpromazine preparations. Theoridazine, again, 25 milligram preparation and 100 milligram preparation. Theoridazine in high dose, like 800 milligram, can cause retinitis pigmentosa, and it has effect on the cardiac system too, so that caution should be taken on the dose of theoridazine. The high potent, more dystonic reactions like torticollis and the like, they do not have such sedative compared to the low potent, and they are not causing postural hypotension as that of the low potent. Typical examples are haloperidone, the injectable form, depot form, with 50 milligram preparation, and the tablet forms with 1.5 milligram preparation and 5 milligram preparation. We have flufenazine, mostly with the brand name Modicate, with depot form or injectable form, 25 milligram preparation. There is also trifluperazine with the brand name Stilazine, 1 milligram preparation and 5 milligram preparation. These are high potent first generation or typical antipsychotics, less sedative than the low potent typical antipsychotics. Atypical antipsychotics or second generation antipsychotics or the newer antipsychotics, less extrapyramidal side effect than the typical antipsychotics. They cause more of metabolic syndrome. Here we have olanzapine, 5 milligram preparation and 10 milligram preparation. More weight gain compared to the other antipsychotics. Even patients who are non-diabetic can be diabetic in the long-term high dose of olanzapine. Otherwise, the extrapyramidal side effect is less. It's somehow sedative. We have risperidone, 1 milligram preparation, 2 milligram preparation, and 4 milligram preparation. More extrapyramidal side effect than olanzapine, and the weight gain is less than that of olanzapine. Clozapine is a drug of choice for treatment-resistant schizophrenia. It's reserved for treatment-resistant schizophrenia. It can cause a drop in white blood cell count, the neutrophils, agranulocytosis, which can be fatal. So regular measurement of the WBC count is very important when patients are on clozapine. We have, it's not well available in our country, but in this group we have quetiapine, arpiprazole, and paliperidone. That's the final one that we will discuss in detail by the experts and the others. Few points on the side effects, mainly extrapyramidal side effects of the typical antipsychotics or first generation antipsychotic. One is pseudo-Parkinsonism, to have tremor, rigidity, and bradykinesia. Maybe benzexol can resolve this side effect. It's named pseudo-Parkinsonism, almost mimics Parkinson's disease, so that it is pseudo-Parkinsonism. Painful increased tone of muscles like the neck muscles dystonia can be alleviated by benzexol and other muscle relaxants. One reason to discontinue treatment is the development of dystonia. The patients complain highly. They can't move their neck muscles. They can't use their muscles properly. Distressing inner restlessness, akathisia, even they can be suicidal. They can't sit in a chair. They are agitated. Mostly physicians may mistake with agitation of psychosis. They will take it, the akathisia, as the agitation of the psychosis. So more and more antipsychotic will be added, then the side effect will flourish. It's not fortunate to develop tardive dyskinesia, even a bad luck for the physician to see his or her patient developing tardive dyskinesia in the long-term treatment of mostly the typical antipsychotics. It is a queroatetoid movement of orofacial area mainly, and involuntary movements, mostly irreversible. You may add vitamin E and other medications can be given. tapering down the antipsychotic is very important, and also shifting the antipsychotic is very advisable. It can involve even the trunk muscles, by the way, so you can have such presentation. Neuroleptic malignant syndrome, it's a medical emergency. Vital sign should be corrected, stable state should be maintained, autonomic instability should be corrected, hydration, vital sign monitoring, curing the antipsychotics should be done. It is a medical emergency situation. So to manage extrapyramidal side effects, one, minimum dose of antipsychotic should be used. You can shift the antipsychotic from first generation to second generation. Beta blockers like propranolol for akathisia, benzexol for pseudoparkinsonism and dystonia, muscle relaxants like benzodiazepines to relax the muscles can be used. And sometimes, like in neuroleptic malignant syndrome, the antipsychotic can be discontinued. So these measures can be taken to manage extrapyramidal side effects. This is the side effect of second generation antipsychotics to develop metabolic syndrome. Weight gain up to 10 kg can be gained with second generation antipsychotics. Patients can be obese, they can develop hypertension, they can be diabetic, and they can have lipid profile derangement, dyslipidemia. So regularly monitor their weight, their fasting blood sugar, and blood pressure measurements, so that, and advise the patient on lifestyle adjustment, regular exercise, dietary management, so that the weight gain can be reduced. Few pointers on poor prognostic factors. Male sex, a poor prognostic factor. Early onset is poor prognostic factor. The disorganized type, family history of schizophrenia, negative symptoms rather than positive symptoms, delay in treatment, 6 years, 7 years, 10 years, in holy water, in traditional healers, delay in treatment is the poor prognostic factor. The chronic, the course, 5 years, 10 years, 15 years with the course of illness, and the poor adherence to medication, discontinuation of medication, repeated admissions to the hospital, and abusing substances, cannabis, chat, and the like, can reduce the prognosis, and repeated admissions also. Previously, there were types of schizophrenia, now it's already omitted: the disorganized type, paranoid type, catatonic type, undifferentiated type, and residual type. But now in the DSM-5, just put the diagnosis schizophrenia. You don't need to mention the type of schizophrenia. As I've said, backbone of management of schizophrenia is antipsychotics. But psychotherapy can add on antipsychotics. So you can use different types of psychotherapy: cognitive behavioral therapy, interpersonal therapy, dialectic behavioral therapy, insight-oriented therapies, individual therapy, group therapy, family therapy, and in our center, skill training is well done. Art therapy, yoga exercise, music therapy, the book club, all these contribute on the psychosocial factors of the patient. But don't forget, with antipsychotics, that you can add the psychotherapy. Otherwise, the management will be hampered unless the patient is on antipsychotics. This is what to say. Then let me say a few points on paliperidone palmitate. So today's this presentation is mainly to say a few points again. The available paliperidone palmitate, or Invega. We have Invega Sustenna monthly injection. We have Invega Trinza every 3 months injection, and Invega hafyera to have on 6 months interval IM injection. It is atypical or second generation antipsychotic. The primary active metabolite is risperidone. So it's prepared in the pure form, also in the injection form. our aim is to introduce the injection form. So really to say it again, we are lucky to have another best antipsychotic in our country in a few days, so that a best option for our patients, for the family, and also for the physicians, and a best alternative. It's a dopamine serotonin antagonist, blocking the serotonin receptors and the dopamine receptors to treat schizophrenia and schizoaffective disorder. It's a monthly or 3 monthly or 6 monthly injection in the deltoid muscle or gluteal muscle. The first injection can be given in the deltoid muscle, then it can be given in the gluteal muscles every month, every 3 months, or every 6 months. It is not approved for dementia-related the development of stroke in demented patients. It's not also approved in children less than 18 years of age. So mainly we use for adults. Schizophrenia affects mainly adults, productive age group. So we have a good option on this regard. If a patient is allergic to risperidone or paliperidone, it is not advisable to use this medication. So the monthly injection, we can use different doses, but the first day dose can be as a typical dose, 234 milligram on the first day in the deltoid muscle. Then on the 8th day, you can have 156 milligram. The dose can be adjusted. A typical example monthly dose is 117 milligram every month. The range can be between 39 milligram and 234 milligrams. So on day 1, on day 8, then every month the injection form Invega Sustenna can be given. The 3 monthly Trinza, first the patient is better to be on Invega Sustenna for at least 4 months before shifting into Invega Trinza, on Invega Sustenna for 4 months. Then the typical dose 410 milligram every 3 months. Every 3 months, 410 milligram can be given. The last 2 doses of Invega Sustenna, that is the monthly injection, should be the same dose for the last, then to shift into Invega Trinza, that is every 3 months. In short, the dose of the Invega Trinza, the 3 monthly injection, is 3.5 fold higher than the dose of Invega Sustenna. So this 410 milligram, you can find it multiplying this monthly injection under 17 milligram by 3.5. It will become 410 milligram every 3 months. So Invega Sustenna, it is monthly. Invega Trinza every 3 months, and Invega hafyera every 6 months. So look the option. If monthly injection is frequent for the patient, we have every 3 months injection. If that's also frequent, we have every 6 months injection. Great improvement on the compliance of the patient. To have every 3 months injection means 4 times per year. Every 6 months injection means only twice per year. Compare it with Modicate, compare it with haloperidol depot injection. So in this case also, on the 6 months injection, first, the patient should be on the monthly injection for 4 months, or at least 1 cycle of 3 months injection of the Trinza. 4 months on Invega Sustenna, or at least 1 cycle of 3 months injection in Invega Trinza, then shift to Invega hafyera. Somehow the typical dose can be 1092 milligram. The last 2 doses of Invega Sustenna should be similar strengths as that of Trinza, and a 2-week gap, either 2 weeks before or on the same day, or 2 weeks after the next 3 monthly injection of Invega Trinza. So in that way, you can shift to Invega hafyera. So we have a monthly injection, 3 monthly injection, twice per year, 6 monthly injection. After 6 months, after 3 months, or every month of injection. Avoid alcohol as far as you are on this medication. Don't be overheated or dehydrated. Sufficient amount of water intake or fluid intake. Avoid sudden shift from sitting position and lying down position because it causes postural hypotension. So avoid alcohol, avoid overheated or dehydrated, you taking large amount of fluid, and avoid sudden shift from sitting position or lying down position. That way you can have the benefit from this medication. Few points on the side effects. If a patient is allergic to risperidone or paliperidone, it's not advisable to give this medication. Extrapyramidal side effects, movement disorders and tremors can be observed. Impact on the cardiac system, prolonging the PQT interval and increasing the heart rate, causing orthostatic hypotension. That's why shifting from lying down position or sitting. Cough and cold symptoms with runny nose and the likes can happen. They can have weight gain, metabolic syndrome, dizziness, lightheadedness, constipation and indigestion, breast swelling, especially due to the prolactin effect, and the prolactin being higher, impotence and breast swelling can be observed. So I'm really happy to hear and to see a new medication, a new leap and a new spring in our armamentum of medications. I'm very thankful for all the members who contributed on this, importing this medication to our nation, to our country. I hope all the physicians on this field will be happy because we have a new approach now to increase the compliance for our patients, to have a better treatment, and another option for the patients, for the family. I hope any new medication will have a higher cost mostly. Availability may be a challenge for a few time, but as far as we are working our best, the patients and for the physicians working on this. Thank you for your tolerance. This is what I have for you. Thank you.